First off, I'm Ramey, Marshell, and the fellows here at UAB in the Division of Cardiology that's not Washington University. I want to thank Dr. Barney first and the FSR for hosting the event and having me involved today. And I want to thank each of you for being here, taking time out of your day. So we'll start off, cardiac sarcoid is much less common than pulmonary sarcoid. However, the past 15 to 20 years, we're starting to learn it's much more common than we previously realized. We originally thought it was less than 5% of the time in patients who had extracardiac sarcoid, like sarcoid of the lung or the skin. However, over the past 20 years or so, we've had autopsy studies which have seen sarcoid granulomas in up to 25% of patients. And now as we're developing more advanced imaging modalities such as the PET scans, which we've already seen, and cardiac MRIs, we're actually starting to see it could be up to 50% or 55% of patients. Now, these patients might remain clinically silent from a heart standpoint, and so that's why they're not being picked up as much. But as you'll see, these patients are just as important to discover, because if cardiac sarcoid does develop, it can be catastrophic in cases. So some of the manifestations of cardiac sarcoid is really going to kind of depend on if it presents with heart failure, if it presents with heart rhythm abnormalities, either fast rhythms or slow rhythms, and occasionally it could present with cardiac death or cardiac arrest, either from heart block or fast heart rhythms or advanced heart failure. From a patient standpoint, it's going to present with frequent palpitations, fatigue, shortness of breath, either with exertion or lying down in bed at night. And they could present with passing out spells. So all of these things are important for you to kind of pay attention to, and certainly let your provider know if you've experienced any. But how it's going to present is like anything else. It's going to depend on the location of the involvement and the extent and severity of the involvement, as well as how active the inflammation is, or if it's at more of an end stage with scarring. Just like you can get in the lung, you can get scarring in the heart. So in this first cartoon up here, you can see just a very small part of involvement up here. This is somebody who's probably going to be clinically silent. This is a patient who might get picked up in an autopsy, or might get picked up on a PET scan that you were doing for lung disease. It might show up with a little inflammation up here in the heart, but it's probably not going to cause manifestations of heart disease. Whereas if you have a lot of involvement in the heart muscle right here in the middle, this is where the electricity current goes through. This is going to present typically with heart block. It's going to cut off that normal flow of electricity, so patients might present with passing out spells. This is a patient who's probably going to need a pacemaker. In a patient like this, where you have extension of the involvement on both sides of the muscle, you could present with heart block again, or you could present with these areas of scarring can cause what we call ventricular tachyarrhythmias, or VT. So these patients can present with fast heart rhythms, again could present with passing out spells or frequent palpitations. And then finally, in a more advanced stage, where you have involvement of essentially the entire heart, this is somebody who is going to present with heart failure. And over time, if this patient's not treated aggressively with immunosuppression, all of this is going to become scarred. The heart function is going to get very weak, and there is somebody that's going to have debilitating heart failure. So what kind of evaluation do we do? Just like anything else, the most important thing is to get a history first and to screen these patients. So each of you ideally should be asked about these things, but if not, you should at least volunteer them if you've experienced them. You should be asked about unexplained syncope, which is passing out spells, or near passing out spells. You should talk about, if you're having frequent palpitations or fluttering of the chest or the heart, you should let your provider know. All patients should be screened, ideally on an annual basis, with an EKG, an echocardiogram, which is an ultrasound of the heart, and or a Holter monitor, which is a rhythm machine that you can wear at home for several days, up to a couple weeks. If any of these are positive, that's a patient who should go on to have some advanced imaging done with a cardiac MRI or a PET scan. just to see if there is involvement of the heart muscle, and if so, to what degree. So this is an example of an echocardiogram or an ultrasound of the heart muscle. You can, without getting into the specifics, this is kind of what the normal muscle should look like. You can see it's nice and thick. Even down here in the septum, it's nice and thick. But in this area, which is typically where we see cardiac sarcoid happen the most, which is up here, this is what we call the base of the septum. You have a lot of thinning compared to the rest of the muscle. And you can see it in each of these views as well. And then on a cardiac MRI, you can see the picture is a little bit better. The detail is much clearer. This is somebody who, again, has thinning up in that the base of the septum. And then here we see abnormal scarring. This is a special technique we can do for a variety of reasons. But in this case, this is somebody with the classic patchy involvement of the heart, which we see often with cardiac sarcoid, with focal scarring here. And scarring can happen for a variety of reasons, but in this case, in both of these cases, this is pretty pathognomonic for cardiac sarcoidosis, and our readers can make this with confidence quite a bit. If there's any doubt, a PET scan is going to be the next best step for us to take, and this I thought was a really good example of somebody. This is from a 45, 46-year-old gentleman who came in, was diagnosed with cardiac sarcoid right here. He had the fluorodeoxyglucose PET scan. So big word. Essentially, this is a glucose analog. What we know is that the heart muscle metabolism uses both glucose and free fatty acids to make energy and for the heart muscle to work. So what we do is we give somebody this glucose analog, and it's taken up by areas of increased macrophages, which Dr. Barney talked about, which are found in these granulomas. So in this case, those areas that have a lot of granulomas, a lot of macrophages, are going to light up nice and bright for us. And that's what we see in this patient who had extensive involvement of his heart at baseline. Now what he did was he had serial scans done after being put on treatment with steroids. So this is 8 months after treatment and 2 years after treatment. And what you can see is the degree of inflammation markedly goes down after 2 years, almost nothing. The rubidium is it's a radio tracer we can inject at the same time. And this goes to the heart muscle, and it essentially tells us how well the blood is flowing inside the heart muscle. And you can see when there was this much activation or inflammation in the heart, there's not much blood flow that's going around. But as the inflammation dies down, now you have lots of dark, which is good, healthy muscle. That's getting really good blood flow. So again, with immunosuppression, you saw not only the inflammation go down, but the blood flow get better. This is somebody who likely came in with heart failure at this point, and probably the heart function markedly improved for this patient. And certainly his quality of life did. So this is what patients most like. When the cardiologist, we rarely get to prescribe this diet to people, but we really want someone to have a high fat. You want butter, lots of meat. You don't want carbs of any kind, but because we're trying to shift your metabolism in the heart to free fatty acids, you don't want the heart muscle, at least for 24 hours, to be metabolizing glucose. So if you cut out carbs out of your diet, your heart's going to be forced to shift to a fatty acid diet. So what's this going to do is when you come for the study, we're going to give you that glucose analog, which is that FDG molecule I talked about. And the only thing that's going to be utilizing glucose at that point for energy are going to be the granulomas. And so that's going to allow us to see only the granulomas light up with that compound. So it's very important if you do get a PET scan, it's very important to follow this diet strictly, because if you don't, you can imagine you could have brightness show up in normal healthy heart tissue, and that could really affect how you're treated. You don't want to get put on immunosuppression medicine just because you had a bad test, for example, and a bad prep. So prognosis from a cardiac sarcoid standpoint, what we have found is that it really just depends on how much involvement of your heart muscle is at risk and at play, and how much it has affected your, what we call the LV function. That's essentially just the overall pumping function of the heart. So if it's normal heart, normal function, the 10-year survival with cardiac sarcoid at this point is 80 to 100%. This is pretty old data. And so even some of these points have gotten even better because our treatment with defibrillators and immunosuppression has gotten better. But in somebody who has severe pump dysfunction, the survival can be quite low when you get out to 10 years. Only about 20% of those patients are going to be alive. But like I said, this is about 10 to 15-year-old data. It's gotten much better because now we're catching these people earlier and we are getting them on better treatment before all this inflammation becomes scar. That's what we don't want. So finally, the management. As we've already seen with each of the other diseases, not everybody requires immunosuppression. The people from a cardiac standpoint who do are the ones who have high degree rhythm problems. So if they're having frequent PVCs, which are extra skipped heartbeats, or if they're having sustained PVCs, which are becoming ventricular arrhythmias, or if they're having conduction block, which is causing them to pass out, or if they're having dysfunction of their heart pumping function. These are all the indications from our standpoint of people who need to get put on immunosuppression. And this is a kind of a basic algorithm of what that might look like. We might put someone on steroids for several months, repeat that PET scan. If it looks better, we might make a decision at that point to start slowly tapering the steroids over about 9 months. Repeat the scan again after stopping treatment. If there's a relapse, we might go back on steroids or we might add a second agent. Alternatively, if that repeat scan was abnormal still, that's when we would talk about adding a second agent, again, repeating scans. So these scans are very important, not just to diagnose, but to survey people in the future to see if our treatment's working. So as I mentioned, some people do require pacemakers. It really depends on how that patient's presenting from our standpoint. But from the cardiologist standpoint, unfortunately, the communities in cardiology, specifically the Heart Rhythm Society, this has become such a big issue even to us. In 2014, they formed a huge writing committee to designate guidelines directly toward cardiac sarcoid to help standardize treatment across just not only the nation but the world. That way, ideally, wherever you're going, especially a big center, they're treating people similarly. So for us in those guidelines, they made a strong point to say even if the heart block got better, these patients are at such a high risk of it coming back, you probably should go ahead and put a pacemaker in that patient as well. And if they have an indication for a pacemaker, usually we put a defibrillator in because a defibrillator can not only prevent somebody by giving them a shock if they needed it, but it can also pace the patient as well. And then we have individual guidelines for putting in the defibrillator, which shocks people out of fast, unstable heart rhythms as well. So that's it for me. Thank you so
All right, while she puts my talk up, I'm going to just start.